20 years ago rather than 30. Gosh, how time flies. And I was part of a tremendous group who established this network at that time, and I'm delighted to see the network is still thriving. So I'm going to try very hard to speak for about the next half an hour and not mention football once. I won't mention football for those of you in Europe for obvious reasons, but I certainly will try hard not to mention football at all again in this presentation. I bring you greetings from cold, grey, wet London. So I hope wherever you are, you're enjoying a better summer at the moment. So my presentation today is about COVID, and I shall pause now to see if I can master the screen share step. And next I will ask Stinker and Ramona if you can see that, and in particular, if you can now see full screen presentation.
Yes, it's perfect.
A thumb up from Stinker, so that's a very good sign. So the topic I shall be addressing is the impact of COVID and implications for future mental health services research agenda. I should be taking, as far as I can, a global perspective, or at least drawing upon the literature and experience with which I'm more familiar. So I plan to do two things. First is to take you through some of the main impacts, at least impacts that we have evidence for from the peer-reviewed literature to date, and then moving on to what I think we need to know, especially what we don't already know. So first of all, what types of impacts are we seeing from this horrid epidemic? So I'll cover this in four particular sections. First, impacts upon the general population. Second, impact upon people with pre-existing, this is pre-existing prior to COVID mental illness. Third, people who provide essential services, sometimes called key workers. And fourth, the mental health implications of having or having had the COVID-19 infection. First then on the general population. So you'll recall some of the initial consequences at the very earliest stages: stockpiling, hoarding, panic buying, in fact, features which you could see as manifestations of health anxiety, fearful preparations for the worst. And then not long before, for some people, layer upon layer of loss or sad trauma because of death and disability. For many people, we shall see perhaps in the earlier stages, profound changes to their pattern as well as quality of life, for example, sleep disturbance, and for many, increased rates of anxiety and depression. And also I will consider the evidence for alcohol and drug use disorders. And I also look at the evidence as we go along about whether there may be longer term effects that could accumulate or persist over years. So from the beginning, it was clear that there were at least short-term impacts on increased incidence of anxiety and depression. We had from the first 3 months or so, data accumulating in my country, suggesting that up to half of the population reported, in general terms, a negative impact on mental health. As you'll appreciate, largely experiences depression or anxiety or both, including massive impacts upon children and their potential for learning. Here we can see early data from about a year ago now from the United Nations, suggesting not just higher rates of distress, again, more or less equivalent to common mental disorders, but also even from the earliest data, big variations between countries in how the population effects were being reported. Here we can see data again from an early stage a year ago from the United Nations about children. We can see a third reporting loneliness, nervousness, irritability, but fully 3/4 looking at difficulty in concentrating. So an early, strong warning signs of impaired learning among young people. And data suggests that over time, the effect upon children has been accumulating. So here we have one of the, you'll see in many of these slides, baseline data prior to 2020 against current data. So again, we see gender effects here as well as age effects. And in these particular data from my country, we can see mental health worse for girls than for young boys, and also worse for teenage than for younger children. And we'll see several patterns emerging about the differential impact of COVID on different segments or subgroups of the population. But as we go along, we need to be careful not to overgeneralize either across time or across place. We can see an interesting study from early this year looking at several different middle or low-income countries, including Vietnam, Peru, and Ethiopia, with very different rates of population impacts, although measured relatively similarly. In relation to adults, again, data, these come from the National Statistical Office in my country, looking at impacts by gender among adults and by age group. And we see at a glance that the biggest impact here, certainly in the first year of the pandemic, is on young women. Women, as we know, more affected by common mental disorders than men, as usual. But also we can see a huge difference between young men and young women in this case. So from the earliest times, 3-6 months into the pandemic, a pattern began to emerge of differential effects on different segments of the community. Women more than men, probably teenagers and young adults more than other groups. And this is borne out here. Again, you can see the patterns for men and women. And as it's in a different study, again, much bigger rates among young women than other groups. Indeed, about half of young women had identified mental disorders or mental distress, in this case, depression, than other groups. Now, this is what is sometimes called a busy slide, which means too much information to absorb. So I want to indicate one particular part of this. And let me check again with Stinker or Ramona if you can see my cursor moving. Does that work? You can, great, okay.
Yes.
So let's just look at this part here. So what we have here is proportions of different populations with depression. This is an early part of this year. And the grey dot indicates pre-epidemic or pre-pandemic, and the red dot, fairly recent data, peri-epidemic. And we can see here, disabled people already had about the highest rates of depression, and they've gone up from about 25% up to about 40%. You can see all the groups have increased, but those groups which have had higher rates have gone higher still. We don't see any ceiling effect on these differential impacts so far. A word now about alcohol and substance abuse. And some of the data here are, I think, truly astonishing. So these are data from a large-scale study in the United States, and look at patterns of use and patterns of heavy alcohol use in different segments of the population. Overall drinking, measured in people drinking each day, increased by 1/7, by 14%, but especially high, 41% increase among those who were already heavy drinkers prior to the pandemic. And again, differential impacts, once more for women, for younger adults, and in this case, for non-Hispanic white people. So we see women here coming up repeatedly as experiencing higher rates and bigger increases in these types of disorders during the pandemic. Now, from our experience of the 2008 to 2010 economic recession, it became clear that in some countries there was a delayed effect of increased self-harm and suicide. And indeed, the experts on economic recessions and health, Stuckler and Basu, wrote, "Recessions can hurt, but austerity kills." So I have been looking to see whether there is evidence that suicide rates are increasing as expected, perhaps 1 or 2 years after the beginning of the pandemic. This because of the direct effects of the infection, but more because of the consequential effects of either unemployment or insecure employment. So just a couple of months ago now, we had this large scale, this global study of suicide rates over and before the pandemic period. And this is a summary of what they found. As usual, the central 100 line is the no difference. And the horizontal pink charts, the lines, show the values and the range of uncertainty in different countries. Looking at, in this case, death by suicide. So values to the left of the 100% line are reductions in suicide. Values to the right show increase. We do not see a consistent pattern of increase across these particular countries. There are exceptions, and you can see, for example, Carinthia, Puerto Rico, Cologne and Leverkusen, for example. And there have been some localized reports, for example, that there was a substantial and unexplained rise in suicide among women in Japan last October. But these are specific reports. The wider patterns here you can see are of no increase, or indeed, in this first year of the pandemic, decreases in reported suicide. So we haven't seen the expected economic impact and death by suicide impact that I expected, perhaps in some of these countries because of economic support or furlough arrangements, which are time limited. So it's becoming clear that COVID-19 and social deprivation are highly interrelated. And to summarize, one can say that existing inequalities in society are amplified, are exaggerated by the impacts of COVID. Indeed, we've had a report in my country today showing that inequalities between parts of northern England and southern England have been further amplified by the effects of COVID. We have detailed data on this from my country, looking at aspects of social deprivation. For example, these are the associations between income and, in this case, depression. So we can see that among those with the higher levels of income, in this case, the equivalent of about maybe 55,000 euros per year, then this is the prevalence rate would be about 12% in a year. We'd expect among all adults, perhaps something between 15–18% for common mental disorders, depending upon how you assess it. But we can see here 3 times the base rate for the richest people occurring among the poorest people as measured by income. And this particular report takes many different angles of attack on the question. It looks, for example, upon security of income, upon type of housing and so on, and the profile, the gradient, is the same in every case. In the second part of my talk, I'd like to look at the question of how COVID has had an impact upon the mental health of people with pre-existing mental conditions. Now, a priori, I would expect a number of reasons why they would have an especially powerful impact. For example, there may be higher death rates because on average, we know that people with mental disorders have more and sometimes more chronic and sometimes more severe physical disorders than the general population. A strong clue leading us to take this conclusion is because among the whole population, we see life expectancy in many countries 10 years longer compared with all people with a mental disorder. And if the comparator is people with severe mental disorders, then they die on average 20 years younger than their counterparts in the population who do not have severe mental illness. There are also reasons of proximity. Some people who have mental illnesses will be in conjugate living, whether in an institution, an asylum, or in residential care homes, and therefore find separation, physical or social, however we refer to it, more difficult. There's also accumulating evidence that some groups have been lesser priorities for protection by personal protective equipment. And for example, in my country, a year ago, it was common that all people in old people's residential care homes would be seen as not deserving or not accessing intensive care or even admission to hospital if they were to become infected with COVID. And also there have been displacement effects. For example, that supplies of psychiatric medication may have been lower priorities and therefore interrupted, while the crisis response was wholly or largely towards COVID and people infected by COVID. There is a number of examples now in different countries. This is from an Eastern European country of conditions within psychiatric hospitals which were already poor, becoming more unacceptable and more squalid as patients, for example, were displaced from 2 wards into 1 ward to create space for acute COVID patients in other wards. Now, these are some of the, I think, most remarkable data that I've come across. This is looking at the effect of infection by COVID upon people with pre-existing mental disorders. And this from a huge study of over 61 million adults in the United States. We can see here that the risk of COVID for people recently diagnosed with either depression or schizophrenia was 7 times higher than the general population. The rate among African American people was 3 times higher than among white people for those with a mental illness. And we can see that for people with a mental illness, the death rate was about twice as high as for people without a mental illness. So these are astonishing figures. Now, clearly, we have to take into account confounders and comorbidity and so on. But just on the face of it, we can see a massive impact on the proportion of the population who are people with mental health. There are particular subgroups I just want to mention within the wider group of people with mental illnesses. For example, people with learning disabilities, sometimes called intellectual disabilities. And we have here data published in The Economist, this from my country again, looking at the adjusted and unadjusted rates of deaths by COVID. In blue, we can see the columns for the general population figures, and in red, just recorded and unadjusted data for people with learning disabilities. Especially in the middle-aged and older groups, far higher rates of death among people with learning disabilities than we would expect from among the general population. This is a particular group, I think, that's being given relatively little emphasis. In the third part of this talk, I'd like to say something perhaps a little more briefly, because it's been widely discussed, about the mental health impact of people providing essential services. I include here both those working in health as well as in social care, but also others providing, for example, public transport, food delivery, or other essential logistical supplies. Now, you'll be aware, indeed many of you, many of us, will be in this situation ourselves, that there have been powerful, sometimes almost irresistible forces and pressures. Periods of leave or holiday cancelled, periods of extended shifts, times when many staff have been either isolating or unwell, and the other staff simply have to do more and do their best. Personal bereavements, but also the impact of working closely with patients, forming relationships and seeing them die, and the stresses of families unable to grieve properly. Aspects called moral hazards, for example, being asked to decide which of 2 patients should be admitted to an intensive care unit for ventilatory support when one has no training, no guideline, or no ethical support in making such decisions. And these are pressures that I've experienced among my colleagues, but let alone think of the pressures in these situations in low and in middle income countries. The data initially suggested that perhaps a quarter, perhaps slightly more than we'd expect, for baseline pre-pandemic levels, a quarter of healthcare staff have common mental disorders. It seems to be that's a substantial underestimate. And from around the world, we've seen reports of staff in tears, not sleeping, really finding this pandemic difficult to cope with personally as well as professionally. We've seen more recently more careful assessments about the true impact in terms of diagnosable mental disorders among healthcare staff. This is a particular assessment about frontline health and care staff, this again from my country, and about half met criteria, diagnostic criteria for depression, about a half for anxiety, about a quarter for PTSD, and any one of the above, 58%. So the majority of people here, frontline care workers, not only people in intensive care or critical care units, the majority had diagnosable symptoms and syndromes. So this means when we're talking with friends, talking with colleagues, the default might be not, are you unwell or are you struggling? But, I'd be surprised if you're not. I actually had a meeting yesterday with a colleague, annual review meeting, an appraisal. And in the middle of the meeting, in which he was reporting good progress and coping, he started crying unexpectedly. When asked, how he'd experienced this year, he simply couldn't maintain his composure. The last of the four groups I want to consider is people who have or have been affected with COVID and some of the many accumulating mental health implications that are becoming manifest. Now, just from the precaution of perhaps having the infection from quarantine and isolation, this itself, of course, can have usually temporary effects, adverse effects on sleep, on confidence, on anxiety, but also those who are affected during the period of infection and subsequently. We're seeing a whole constellation of neuropsychiatric symptoms that are quite often found in the acute phase delirium, and then sometimes post something equivalent to a post-stroke depression, as well as chronic fatigue syndromes, now sometimes called long COVID. Along with isolation comes a lesser degree of social support, especially those who are not technically sophisticated to access online help and contact. Some people have reflected cognitive impairments, such that they wouldn't be able to manage a Zoom meeting and so on in any case. And there's accumulating evidence now over the whole of the COVID period of stigma against people in any way associated with COVID. So there are, from early stages, these odd reports about fleeting or unusual patterns of mental illness symptoms. From an early stage as well, suggestions that 20, perhaps 25% post-infection had persisting neurological or psychiatric symptoms, most often, of course, anxiety and depression. And here, about a third in one. So we've seen between 20, 30, 35% people with clear-cut mental health symptoms, something like double expected pre-pandemic rates. And also some evidence that the mental health impacts of COVID may be even greater than other acute or chronic viral infections. You can see here several comparators, and it looks like the risk of developing psychiatric conditions, in this case diagnosable conditions, is perhaps twice as high as for some other somewhat similar conditions. So the idea that there might be an infection and then a consequent onset of a psychiatric condition is now becoming too simple to sustain. And indeed, a recent review of this by colleagues in Oxford talks of a bidirectional association. And indeed, we could now apply the concept of syndemics, of multiple concurrent long-term symptoms and syndromes taking place at the same time to the implications of COVID. And you can look in any direction and you'll find that the risk of the other aspects will be increased. One of the most affected groups are people who have had, perhaps are still having, but who have had ventilatory support. We can see one particular study here from earlier this year in BJP Open, looking at PTSD in relation to the level of ventilatory support. And the higher degree of mechanical assistance, the higher the level of subsequent PTSD, let alone what the experience of people already in intensive care who are not sedated or in induced comas may be. I mentioned a word about stigma, and I'll say a little more about this now. It's clear from the earliest days that people who had infections were being shunned, perhaps evicted from their housing, but also staff working in hospitals who were or who were assumed to have contact with COVID were being systematically ignored or rejected by some sections of society. In some cases, of course, the idea of the stigma of the physical sign was manifest. In this case, somebody in India with an indelible stamp on his hand. This is somebody standing outside the Ministry of Health in Madrid, a person of Chinese heritage, saying, "I do not have coronavirus, non tengo coronavirus," because she becomes sick and tired of being given stigmatizing comments and avoided by friends and colleagues. And in particular, especially in the most recent period, we've seen this targeted in so-called Asian hate crime against people, for example, in the United States, who have reported being vilified, including on social media, which is a channel of extreme invective because of their cultural heritage. Indeed, with colleagues who are experts in the areas, for example, of epilepsy and TB, tuberculosis stigma, we recently did a rapid review on the topic, making specific recommendations, one of which was to stop using country names for the types of India variant, Brazil variant, and not least of which, because this was recommended 10 years ago now by the World Health Organization. Unfortunately, they have now issued their own Greek letter nomenclature, and also certainly in many of the accounts I see, alpha, beta, delta variant are now becoming more commonplace, although people still say delta variant, still originally found in India, and so on. So in the last few minutes, I want to move on to the research implications, because we, as ENMESH, are a research network. What do I think are the major questions? So I'll go through each of these issues and to give you a brief account of my suggestions about the work that needs to be done. Oops. And I'm drawing here upon several source materials. One is a very nice overview about the impact at the community level, led by a colleague in Canada, Daniel Bigot. Also upon a recent, really quite extensive review in Lancet Psychiatry, led by Lola Kola. And also, I want to look at the question about whether services are increasing in relation to increasing need. So to summarize a lot of what I said a moment ago, we do have now strong data, where we have data, which is mostly from high-income countries, of increasing incidence and in some cases persistent increasing prevalence, especially of common mental disorders and alcohol use. If that's the case, at least throughout the last 12 to 18 months, is it also true that governments and other providers are stepping up the quality and the level of care to respond to this challenge? Well, so far the answer is no. We don't yet have much data about this, but the WHO Central Office in Geneva did coordinate an early rapid appraisal. They contacted all, I think, 193 member states and asked them to give a short questionnaire response. Most countries did respond, 130. And of those, 75% said that they had complete or partial disruption to specific mental, neurological, and substance-related services. And we have, at the moment, anecdotal evidence from many countries that staff from mental health care are redeployed into general health, especially COVID health, that facilities such as wards are closed to mental health and reused for physical and COVID-related purposes, and that the resources used, for example, for drug supplies, are also being diverted. So far, the limited data we have is that the response of services is becoming less, while the need for mental health services is becoming more. Here's another indication of this under-response. These data from my country showing the numbers of people diagnosed with depression over the last 4 years. Now, this is a very coarse, it's a national assessment, and it's GP or family practitioner diagnoses. But we would expect an increase over this period for true cases. In this case, we have reports of identified cases in primary care going down substantially, in part perhaps as people avoid mixing with anyone, including going to a primary care centre for avoidance of infection, but whatever reason, a reduced recording of depression diagnoses. So then there's further data here about low and middle income situation. I'm running out of time, so I'll just leave you with that and a further paper here about the health system implications of COVID. I'd be happy at the end when I give you my email address to send you on details of these papers. So to come back to my list of questions before I finish this talk. I think we need to make careful longitudinal assessments about the incidence and prevalence rates of many of these types of mental disorders that I've discussed over time to see the short and the medium and the long-term impact. We need to track carefully whether provisions mean that the mental health gap between true and treated mental illnesses is in fact decreasing or, as I suspect, increasing over this period. We also need to see whether the services that are provided are maintaining a minimum quality of care or maybe being degraded by disinvestment, especially using service user ratings. We need to look at the balance of supply and demand, for example, people avoiding going anywhere near a health service for fear of infection for COVID, and to see what factors are being amplified or reduced. For example, whether the stigma of mental illness is actually increasing or not over this period. I mentioned that the difference between true and treated prevalence is often called the mental health gap. We need to measure this and track it in different times and different places. In most low-income countries, the gap is 90%. In many of our more affluent European countries, it's perhaps 60 or 70% of the gap. We need to check if we're actually reducing or increasing that gap over time. We need to keep a close eye on investment in mental health care, whether it be in social or in health or in other sectors, and track if governments are backing away from proper investment in mental health or delivering as they should. I won't talk today about the 6 pillars of the WHO health system strengthening, and perhaps Dr. Chisholm will mention this later, but this is one way of assessing whether the structure of a service is adequate. And we need to keep an eye not just on provider or middle level, facility level investment, but also on the macro level as well across the whole health system. And look at the extent to which we are investing in the health service, not just for the COVID, but for the post-COVID period, including the real prospect of initially 25% of people infected by COVID having long COVID symptoms, similar to post-viral fatigue. And this may be a challenge for years to come. So to summarize, I wanted to do 2 things in this presentation. First is to say something about the impact on these 4 different groups of what we know so far of this terrible COVID-19 pandemic. And then to give you an indication of where I think some of the priorities lie, both to identify new challenges, but already to track and to change to reverse what I think is the increasing mental health gap from the impact of COVID. If you'd like to hear more, do contact me in a moment. I'll give you my email address. And these are my closing key messages. To a large extent, the mental health elements of COVID have been neglected. And in that case, some colleagues in China have called this a parallel epidemic, one that in the long term actually may have more pernicious, noxious impacts on society than the, we hope, medium-term impacts of the virus itself. So please do contact me if you'd like to follow up any access to any of these sources. Thank you very much for your attention. And I pass you back to Stinker for the time we have for questions and comments. Thank you.